Hi, I'm Dr. Vaasanthi, consultant cardiologist at Women's Hospitals, Champapet. So today we'll be discussing about the topic of thrombolysis and acute myocardial infarction. And so what is this thrombolysis and what are its indications and the contraindications and the benefits of the thrombolysis we'll be discussing here. So what is acute myocardial infarction? Acute myocardial infarction is an emergency situation where there is a complete blockage of the coronary artery, and in such cases early perfusion is a critical because the time is a muscle. How much delay we are going, how much time is getting delayed, that much amount of the muscle is going to be damaged irreversibly. That ultimately leads to the LV, more of LV dysfunction and increased mortality. So usually where we consider thrombolysis, in the ACS patients also we divide as a STEMI, NSTEMI and unstable angina, and thrombolysis is going to be considered only in the STEMI patients because the STEMI has a complete occlusion of the blood vessels and thrombolysis is going to work here. But in NSTEMI patients, usually there is a partial occlusion of the artery that is resulting in the MI. So if we do thrombolysis in NSTEMI patients, that leads to a complete blockage of the coronary artery. So we avoid thrombolysis in STEMI patients and do consider thrombolysis in the STEMI patients. So what are the goals of the treatment? We have to restore, by doing the thrombolysis or early perfusion, we are restoring the blood flow. We are reducing the infarct size. We are reducing the amount of the muscle that is getting damaged irreversibly. This in return leads to the preserved LV function and reduces the mortality. So, what are the methods of the reperfusion is? One is a gold standard is a primary PCI, percutaneous coronary angioplasty. That is a gold standard method. If PCI is getting delayed, if it is like onset of the patient's symptoms, patient is presented to the hospital and it is taking more than 120 minutes to patient to undergo the coronary angioplasty. So the hospitals where the PCI, which are not PCI capable centers, in such cases, it is better to go with the thrombolysis. So what is thrombolysis? Thrombolysis is an agent, thrombolytic agent we'll have. So when we infuse this thrombolytic agent, usually we do the intravenously. This leads to the dissolution of the clot. Whatever the clot that has been occluding the artery, that gets the dissolved. It acts by the mechanism where it activates the plasminogen and converts to the plasmin, and it will break the fibrin clot. So where we are going to consider this thrombolysis? From as we already discussed, we are going to consider it in the STEMI patients. And what is the time period you can go for the thrombolysis? Usually when the patient onset of the symptoms, we take that window period as a 12 hours. Within 12 hours, you can thrombolyze the patient. But post 12 hours, the thrombolysis benefit is nil or it can be a more hazardous. And if thrombolysis is done within 6 hours of the onset of the symptoms, in such cases, it is going to be more beneficial. So what are the contraindications? When we have the indications for anything, we'll have the contraindications too. So coming to this contraindications of the thrombolysis, we have the absolute contraindications, we have the relative contraindications. Absolute means where we should not perform the thrombolysis at all. Relative is where we can opt for thrombolysis, but not ideal patients. Absolute contraindications is previous any hemorrhagic stroke, but like patient had a stroke that is because of the hemorrhagic CVA. So such cases we completely avoided thrombolysis, or it was a ischemic CVA in the last 3 to 6 months. In such cases also we avoid thrombolysis, and other causes is like major trauma or any major surgery in the last month, any CNS tumors or active bleeding. In such cases, we do not consider thrombolysis. Where we can opt, we can consider for thrombolysis is, but not 100% ideal patient is cancer patients, age more than 75, where the bleeding risk will be more, or a transient ischemic attack in the last 6 months, or patient is on anticoagulant therapy, active anticoagulant therapy, and we give thrombolysis, there is an increased risk of the bleeding. And some other causes like active peptic ulcer disease or liver disease, pregnancy, postpartum, immediate postpartum. In such cases, we have to think before going for the thrombolysis. And what are the thrombolytic agents we'll be using? The most common thrombolytic agents we'll be using is streptokinase, altiplase, tenecteplase, and reteplase. And the most common among these which we use is tenecteplase. So this ideal time when we have to like patient has presented with the symptoms of less than 12 hours. So patient, when he comes to the hospital, then the door to needle time means within how much time you have to administer this thrombolytic agent is less than 30 minutes. That we call it as a door to needle time. So apart from this thrombolysis, we also keep a patient on the antiplatelets, heparin, statins, and beta blockers. So when we do consider as a successful thrombolysis, okay, we have given the thrombolytic agent. Patient should ultimately undergo the coronary angiogram and followed by the coronary angioplasty. But if the time is getting delayed for this angioplasty, we are considering this thrombolysis. And after thrombolysis also we have to observe for the symptoms because it can be successful or unsuccessful. Unsuccessful cases, they have to immediately transfer to the emergency PCI. And successful thrombolysis, you can have the wait period of 3 to 24 hours. In that period, you can perform the PCI. When the patient is having a decreased chest pain, whatever the STEMI patients we consider, STEMI is categorized based upon the ECG finding of ST elevation. And these ST elevations are coming down after thrombolysis after 1.5 hours, around 90 minutes. And there are no reperfusion arrhythmias, means when we are restoring the blood flow, there can be a VT or radioventricular rhythms and everything. When we are not having the VTs can be there. So when we are not having such VTs or ST segment has decreased, elevations has come down, patient is clinically stable, the chest pain has decreased, we consider it as a successful thrombolysis. So there are the complications related to this thrombolytic agents. One of the most adverse complication is bleeding. And this bleeding can be in any form. The most common is intracranial hemorrhage, and there can be hypotension, there can be allergic reactions. And as we discussed about the agents, common agents which we use as thrombolytics, the streptokinase is having more of allergic reactions. And usually, if we are thrombolizing a patient with a streptokinase, it is contraindicated that another 6 months to 1 year, you should not reuse the streptokinase again. So thrombolysis versus PCI, which is a better? Obviously, the PCA is the gold standard method, but when the PCA is unavailable or when it is taking too much time for the patient to get to the PCA, in such cases, a thrombolysis is a better option. It is a widely available and it's a faster method. What is a pharmacoinvasive? Pharmacoinvasive is, as I told, like successful thrombolysis patients, we can wait for 3 to 24 hours. So thrombolysis, when it is done first and followed by the PCI, that is called as a pharmacoinvasive method. So I like to conclude in my slides is that never underestimate the thrombolysis. If PCA is there, you go ahead with the PCA. That's a gold standard method. But in case if the PCA is not available, do not waste the time. Go ahead with the thrombolysis. It's a life saving, especially in the STEMI patients, and it's more effective when you do more early. So at the end, do not delay do not delay reperfusion. But before considering for the thrombolysis, do check your checklist. I mean, see for the contraindications, and post thrombolysis also do monitor the patient for any bleeding manifestations. Thank you.